What's the efficacy of these drugs, Dr. McCrae? And do you feel that there are any differences other than the ease of use or possible insurance issues or maybe even financial? Are there any clinical differences in terms of efficacy between the two TPO mimetic agents?
Well, they're both TPO mimetics. They both act on the TPO receptor, but they're not the same drug. And I think an important thing to emphasize is that you can have patients who fail to respond well to one of these who respond very nicely to the other, even though basically they work through the same pathway.
And it can work both ways.
And it can go both ways. I think that there's some class-specific toxicities that apply to both of these, mostly a few percent incidence of a little bit of reticulin in the bone marrow, which is not the same as collagen fibrosis. It's mild reticulin fibers that really probably don't have much clinical significance and go away if the drug is stopped. Of course, Altomare has a few percent, can develop some elevated transaminases, which usually only are mildly elevated, and again, doesn't really have to be treated, but an occasional patient, rare patient, can have marked elevation. So you do have to monitor that over time. I agree with what Dr. Gernsheimer said about, I think romiplastim is a great drug, but I do think the management, some people really do overreact to platelet counts. Some folks try to extend out the treatment, from instead of weekly to say, well, maybe I can get away with this every 2 weeks. And the platelets can really drop very quickly, and the patients can get very thrombocytopenic. I use both of them. Most of the patients I see prefer the oral medication, and they don't like to come into the hospital and park and pay for parking and all kinds of things like that. But I actually use romiplastim some in hospitalized patients, because I think the thing with romiplastim is, the recommended starting dose is quite low, but you can increase that tenfold and still be within an approved range. And I think you can really get more of a wallop at 10 micrograms per kilogram if you need it. If you have somebody who's in the hospital and is really bleeding, I will start at quite a high dose, actually.
And the patient is getting it, and that there's not a problem with absorption.
Exactly.
Yeah.
Right.
I think you made a really good point that I want to elucidate on. When people stop, so the way the protocol was written, because we weren't really sure what we were going to see, both protocols, was if the platelet count went over 400,000, the drug was to be held. And what we quickly saw was that, and this happens in about 10% of patients, if you stop either one of these drugs abruptly, patients can fall well below baseline. And we had a couple of patients on study, and then there were protocol violations because I wasn't willing to do it again, that when they went up to 800,000 or something like that and the drug was held, within days of missing a dose, they showed up in the emergency room bleeding.
So we've seen it too.
Right. So I think you have to be really careful. I can talk about off-label what I do when a patient's platelet count gets really high, is I don't stop. I taper. I might decrease the dose by a third or by a half. If the count is really high, I might tell the patient to take an aspirin until the count comes down a little bit.
Okay.
Which they just love. They're like, I'm allowed to take an aspirin? It's just so exciting. But I think people have to be really careful because they read that label, and there is a warning at the top that got added because people started complaining, I held the drug according to what the FDA said I was supposed to do, and I got into trouble with it. So there is a warning at the top that if the drugs for both of these drugs, are abruptly discontinued, very low platelet counts and bleeding can occur.
And let's say that you decide to actually stop therapy, not holding as per dose adjustments, but you're actually stopping therapy. Would you taper the drug? Always.
Always taper. Usually, I begin to taper the drug anyway if a patient is consistently over 100,000.
Why?
I start backing down. Because we have seen, and I've seen several patients like this, we've seen patients who go into remission. And you don't want to miss that remission.
Simply by the continued use of a thrombopoietin mimetic.
And we don't know why.
Do we have any data to further characterize the percentage of patients that will experience that?
There are some data that suggest as many as 1/3 of patients will, if you continue this for 1 to 2 years, will go into a spontaneous remission. Why that happens, there's lots of interesting questions about that, lots of interesting data about what's happening with TGF-beta, what's happening with Tregs. I don't think we really know.
Yeah.
We do know from some of Saylor's data that despite what we all learned in medical school, that 85% of patients who come in as adults are chronic, that's it. And they're going to have this forever, and they're never going to be cured unless you do a splenectomy. Saylor presented some data, has published some data suggesting that up to 40% of patients, if you wait long enough and just support the patient, will eventually, over the next 5 to 10 years, go into remission.
So we know that the TPO receptor agonists are effective. Where do you use them in therapy? And is it a particular type of patient, Dr. McCrae, that you like to use these drugs with, or is it a certain line? How do you fit them into practice?
I mean, I think any ITP patient is a candidate for these drugs. You know, I think as Dr. Gernsheimer talked about, this early data using them very early in the course is quite interesting and definitely worth considering, certainly studying. Otherwise, you know, it becomes a second-line therapy along with rituximab, along with splenectomy. Those would be really the three things. There's, of course, other things that you might also consider second-line therapy that are less efficacious, but the three primary choices in my mind for second-line therapy are TPO agents, splenectomy, or rituximab. And again, individualization of therapy is really important. I mean, and some people, you know, when you talk with them about the different options, they might say, well, you know, I'd like to try this IV drug and maybe not have to take something. Other people would say, you know what, I don't want to do that. I just want to take a pill or get a shot once a week. So it's all good, you know.
Now, I want to go back to something that you said. So you do give a trial of stopping a TPO mimetic to see if there has been a remission. Let's say that there has not. What is your longest time that you've had a patient on a TPO mimetic? And really, what's the data for long-term use, safety and efficacy?
When did we start the first trials? I've had patients on since the first trials, so probably over 10 years.
Yeah, that's 10 years.
Yeah, I've got several patients who have been on since the very first trial that was done with vermiplistim and then with eltrombopag. So patients who are on for more than 10 years.
Yeah.
They're very happy. They haven't had any issues. Some of them have been tapered off therapy. So, and they're quite happy with it.
Yeah, yeah. Is there any cumulative toxicity that you see at all?
I have not seen any.
With either of the agents?
No, I really haven't. Yeah. They seem to be incredibly well tolerated.